Without any further ado, I'm going to introduce our chair, Seddy Fredericks.
Thank you, Natalie, and good afternoon, colleagues, friends. I'm delighted to welcome each and every one of you here to our AGM this year, those in the room and those who are taking part in this afternoon through our live stream. A huge thanks to you all for your continued support of and contribution to the NHS. I hope you've had the opportunity to spend some time in the marketplace and talk to our colleagues, and can I thank them for their contribution this afternoon. Our annual general meetings mark a significant moment in our calendar as we come together to review the year that has passed, reflect on and share our achievements, and give you a sense of the challenges that we have faced, but also, and importantly, set out the path for the future. It's really important that we frame that, or I like to frame that, against one of our major objectives, and that is to lead on the development of healthcare strategies for our health system. But we don't do this work in isolation. We have worked with our NHS colleagues and many others over the last year to move this crucial agenda forward, and we will continue to progress this work together in the coming year. The past year has been a year of change and challenge, not only locally and regionally, but of course at national level. We have built an excellent relationship with the still relatively new administration at Medway Council and have continued to work positively with colleagues at Kent County Council. Together we have worked hard to strengthen the integrated care system, and following a period of review and working with our wider stakeholders, we've strengthened our integrated care partnership. Has it all been plain sailing? No, it hasn't. Not at all. We've had our disagreements internally. Of course, Paul and I never disagree. And we've also had our occasional disagreements with our partners from time to time. Are we, as an ICB and as a health system, where we want to be? No, we are not. But I can assure you that collectively, we've never wavered from our commitment to provide the safest and most consistently high-quality healthcare services to the people of Kent and Medway. Our Together We Can message remains strong and true. I mentioned earlier the changes at national level, including the message from the new Secretary of State for Health and Social Care setting out the journey he wants the NHS to take. Very few would argue against moving the NHS from hospital to community, from analogue to digital, and from treatment to prevention. And I'm pleased to report that in our relatively still short life as an ICB, we've already set off down this path. We await the new NHS 10-year plan, which should come out early next year, which will set out in more detail how we will take these challenges forward. But I do believe we're very well placed to respond to whatever is asked of us. I'd like to take a moment to acknowledge the hard work and dedication of our entire ICB team and colleagues right across our health system. The success we celebrate today is a collective effort, and I extend my deepest gratitude to everyone who has contributed to the delivery of our healthcare services across Kent and Medway. As we move forward, we are committed to building on the solid foundation we have laid over the last 2 years and push the boundaries of what we can achieve together. The years ahead will bring fresh challenges, but also new opportunities and exciting possibilities. We must continue to work together and be prepared to take risks if we are to succeed. But most importantly, we must remain positive and optimistic in the face of these challenges. We must be bold and be willing to reimagine our health system. But we cannot achieve the changes we must see without every organisation in our system, from community pharmacists and primary care through to our acute, community and mental health trust and others, committing to a shared vision of the future and be willing to come on the journey with us. At the same time, We must listen to and engage with everyone who has a stake in our NHS, including patients and our wider community. And to that end, in case you have missed it, we're advertising for a People and Communities Champion to join the board. The advert is now out, and the closing date is the 10th of October. Please pass the word on. We really want a good field of candidates to consider. I'd like to extend my heartfelt thanks to our board members for their leadership, guidance and commitment to upholding our values and vision. To our partners, thank you for your unwavering support. It is truly appreciated and is critical to our success. Collaboration has been at the heart of our progress as an ICB, and we are grateful for your continued trust and support. Lastly, just to repeat my appreciation to our staff and the wider NHS family. They have played an integral role in driving our success. It has not been easy for them, but I continue to be in awe of their commitment and sheer hard work. Today's AGM will provide a platform to discuss in detail our plans, financial performance, and the direction in which we're heading. We invite you to actively engage in our discussions this afternoon, share your perspectives, and ask any questions you may have. I'm confident that with your continued support, we will rise to meet the challenges of the future and take opportunities in the coming years and beyond. Thank you for being here today. Let's continue working together to shape a bright and successful future for the NHS in Kent and Medway. Thank you very much. We're now going to show a short film which will just share with you some of the work we've done over the last year or so. Thank you.
Good afternoon, good evening, good afternoon. I'm Paul Bentley, I'm Chief Executive of the ICB, and I want to take you through a relatively short presentation, but let me start by adding my thanks to the chairs. We only do what we do because we are able to work collaboratively and in partnership with a lot of the people who are represented in this room, and my thanks to the staff who work in NHS and social care across the whole of Kent and Medway, and it's lovely to see so many people represented this evening. I have to pull this down because Seti's about 6'8", so I've struggled with this previously. It's helpful just to remind ourselves as ICBs go into their third year of operation about what we are and what we do. So just to remind people, and this information is in the booklet that is in front of you, we exist to improve health and health care for the people of Kent and Medway. We position ourselves consciously and statutorily as a leader in health, but very importantly, and I think that this will come through what you are about to see later, we have to meet population need. Population need is not always about what the NHS does, it's about the wider determinants of health, and I'll explain that in a minute. This year, and again, Ivor will go through this, and the figures are in the pack in front of you, we are an annual budget of £4.2 billion. That is the scale of the operation. But we are limited, and the NHS is limited by Parliament in terms of the amount of money that we have to spend, and we have a statutory, a legal duty to comply and make sure we do not spend more than we have. We try, and we don't always get this right, to deliver through partnership, through engagement, through working with, not doing to people, and we make sure that we coordinate approaches and we track them, and I'll touch upon that in a minute. And very importantly, we measure our impact by the population that we serve. So we serve now just about 2 million people in Kent and Medway, and I'll touch upon this later, but in an integrated care system where you can drive from the top to the bottom and the side to the side, there is a 12-year age gap depending upon where you are born. And one of our most important duties is to narrow that and to bring that up to the best rather than down to the worst. So, touched upon by the chair, but really important for me to reiterate, we as NHS Kent and Medway are one of the three statutory partners, Medway Council and Kent County Council, and we are equal partners. The scale of the integrated care partnership is really important, and we have worked collaboratively, and we will continue to do so with our partners. It was really important during the year that we're covering now that we approved, and all three partners approved, an integrated care strategy. It's available on all of our websites, and it looked at what everybody can do to improve the health of the people we serve in Kent and Medway. It is an absolute commitment of the Integrated Care Board, of which I'm the accountable officer, that we will continue to delegate. We will continue to delegate resource and people as close to the people we serve as we possibly can. And one of the most important vehicles to do that is our 4 health and care partnerships, geographically based. But we've also made some real progress this year in terms of how we operate with things called provider collaboratives, where sectors in health come together and work more collaboratively. An example of that, I just identified one, is emergency and urgent care. We have a number. And what we've also done during the year that we've covered is to establish our system structure and architecture. It's always being iterated, but how we work, what we do and how we do it are incredibly important. And I would add that we've made progress this year in terms of building that on the basis of trust and relationships. What we deliver is built on trust and openness and the relationships that we work with various parts of the system. This document is an extract from some work that we have done to establish a strategy for the NHS in Kent and Medway. So it's only a part of the work that we do as an ICB. But I just want to draw your attention. This is what we've called our case for change. This is what we need to do differently. This is a reflection of the situation in Kent and Medway earlier this calendar year. And I just want to draw the room's attention to a few bits that are particularly salient. If you see halfway up at about 9 o'clock, in NHS buildings, we have a £500 million estate backlog. To fix our buildings will cost £500 million. At the top right-hand corner, 12 o'clock, we are spending £250 million more than we have each year, and Kent and Medway has done that for some considerable time. But I would say equally shocking is down at the bottom, that figure there that has done some analysis, and you'll hear from Rakesh and Rachel a bit later, but the analysis is that if we carry on as we are, in 5 years' time, we will have 70. So 70 is that half of the room. So imagine that half of the room arriving in our EDs every day, and we have to treat them, and we have to find a way to treat them. And that is not right for the people we serve, and it's not right for the system, and we need to find better ways to deal with that. But I would also say that demand regularly, so I'm moving to the far right of this chart, in general practice in particular, but not limited to general practice, each day in Kent and Medway, there are not enough general practice appointments. That is not because of the incredibly hard work of our colleagues in general practice. That is a mismatch between demand and supply. And we need to address that so that people can get the services that they need in primary care. So if that is the position, we have obviously much work to do. And at the beginning of 23-24, we set ourselves 6 priorities. I won't go through these in detail, but I think it's helpful to get a sense of the work that we've done. So we know that 2 years after a global pandemic and a pandemic in this country, that we have way too many people who are on elective waiting lists, and they are waiting too long to get through the system. In a population that we serve of 2 million people, there are 200,000 people on our elective waiting list. 1 in 10 people in Kent and Medway is waiting for an operation, and we need to reduce that time and that number. We felt it was beholden upon us as the system to be the most efficient and the most effective that we could possibly be. And so, like every ICB in the country, we took the commitment to reduce our running costs by 30%. In year, to reduce those back down, and to do that by changing the way that we operate. Again, Ivor will talk about this in a moment, but to deliver our financial legal duties is really important. To make sure that that integrated care strategy that I talked about just a wee minute ago was delivered and was part of the operation. To work with colleagues in primary care, and primary care is not just GPs, primary care is community pharmacy and dentistry and optometry, to transform how primary care is working. And finally, the NHS in England employs 1.4 million staff. They are what makes the NHS, and if we are not a good employer across all elements of Kent and Medway and all elements of our workforce, we will not be able to deliver what needs to be delivered. So we need to continue to transform our workforce. Some of these have been mentioned both in the film and in the report that the chair gave, but I think it's important to recognise achievements. I'm incredibly proud that the year that this covers, we've opened Eden Bridge over in the west of the county in conjunction with partners and changed the model of care. We've put the extra 11 million, so just under 1 million a month, appointments into general practice. We've increased the availability of dentistry in terms of dental activities, but we absolutely recognise we have more to do, and that more to do is covered by the primary care strategy that the board approved earlier this summer in May. There is no health without mental health. So we can't look after people's physical health and ignore the mental health needs. So I'm really proud again in this year that we've established 2 safe havens for people in the darkest places in terms of mental health. We've increased the access to community crisis in mental health. We've identified 52 additional dementia coordinators, including some specialist GPs, 9 who are working in that space. And we've managed to make a dent. We are not there yet, but we managed to make a dent so that people can access talking therapies, which are alternative ways for people to look after their own mental health. And I'm really proud that across 42 integrated care systems in England, the length of time that people in Kent and Medway wait to get through EDs is the shortest of all of those. It is the strongest. We get people through. I would add that if you're in an ED and you wait 4 hours, it feels like an awful long time. So we're not in the right place, but I'm proud that we are getting to the right place. And again, more information in our annual report. But we have more to do. And so this is just a sense of the scorecard in terms of where we came into the year and where we leave the year. And I'll just highlight 1 or 2 bits in this. We have definitely made some progress in terms of elective waits. That is patients waiting for an operation. But we still have 2,500, or we had 2,500 people waiting at the end of the year who had waited over 65 weeks. And I absolutely realise if you wait for an elective operation for a year and 3 months, that's an awful long time normally to be in pain, and we are working really hard to bring those down. So more work to do. Really pleased, I touched upon it a minute ago in terms of the number of appointments. These are the number of appointments in general practice, real success. And what we also have now is we've got something called R's roles. So if you make an appointment to go and see your general practice, there is a possibility you'll see your GP, but you may also see a physiotherapist or an emergency practitioner or a pharmacist, because there are occasions when those people can do the job that they need to do. And we now employ over 1,000 of those in Kent and Medway, which is up by a further 200, 300 in the year. But I would also draw your attention to the 3 tables at the bottom, or the 3 charts, where we are working incredibly hard, and this is a reflection on the staff in the system, but we're not making the progress that we'd want to in terms of cancer. 4 hours, we are the best in the country, but we're not moving very much further forward. And our diagnostics, where you go and be scanned or you're going to be tested for something, we are not making the headway that we want to, and we want to make more of that. We've opened something called CDCs, Community Diagnostic Centres, but more to do. So my message is more to do. This is available in your pack, but I think it's an important reflection. Every health provider in Kent and Medway, and some that operate across more broadly than Kent and Medway. So, for example, South East Coast Ambulance Service, CCAM, is rated and is quality surveyed. And that is an important part of our role and the role of NHS England. And you see down the left-hand side something that really gives me a level of confidence, but more to do. So we have outstanding trusts, we have ratings that are good trusts, but we also have trusts that are requiring improvement and more to do and further work that is required. And what we do in that space is that we quality survey all of those organisations. And our clinicians, Kate Langford and Paul Lumsden, Chief Nurse and Chief Medical Officer respectively, work with the clinicians in those organisations to make sure the standard of care is what it should be. This is meant to be about last year, but inevitably, as you click from the 31st of March to the 1st of April, your thinking and your thoughts turn to the future, as do mine. So very early in the year, we set out our stall for 24-25. 5 priorities, all identified there. Real progress about system integration, how we work together in collective working. Absolute need to deliver core standards and reduce those waiting times and reduce the number of people. Reduce that 12 years life expectancy difference depending upon where you are born in Kent and Medway, and we need to reduce that. To have the very best workforce we possibly can, to make sure it is sustainable, to make sure that every colleague in the NHS feels valued, and we do that within the amount of money that we are allocated. Because if we do that within the amount of money we're allocated, we will manage the money, we will not have the money manage us, and that's really important. Just a couple of tee-ups really for where we are. We have worked as a chief executive community in provider trusts to look at what the NHS needs to look like in 5 years' time. And we've identified these 4 areas of work. So the first one and the most important one, patient access, patient outcome, patient experience, what we do for the people we serve. People in this context is the NHS workforce, the broader NHS workforce. We need to be sustainable. We need to deliver sustainably, and that's sustainable across all elements. We cannot continue to go through peaks and troughs as we have done previously, and we need to do that within the financial envelope. And I think off the back of discussions we've had as a chief exec community as recently as last week, the NHS strategy will be signed off and will be approved, and I very much hope boards will ratify that in the coming 2 months. So finally from me, just reflections. I'm absolutely convinced that the system is where the solutions are. It's the organisations. It won't be addressed by single organisation or single sectors. We have to work collaboratively. There is a narrative, and the chair referred to it a wee minute ago, from the Secretary of State for Health and Social Care, and it is DHSC policy that the NHS is broken. But my reflection upon that is it's broken but not beaten. If you go into an NHS service today acute mental health primary care pharmacy, I think more than not, you will be greeted with a member of staff who wants to do the right thing for you and wants to do it in the right way. And it's our job as the leadership of the NHS in Kent and Medway to help them do it. So I don't subscribe to the idea that it's beaten, because it's not. We've got the frameworks, we built the platform. I think we have to do two things at once, which is to tackle today, carry on tackling today, whilst addressing what tomorrow looks like. And tomorrow is 5 years in NHS terms. And I don't think as an NHS we should be working harder. I think we should be working differently. I think we should be working together, and we should be working collaboratively. But I absolutely believe that the NHS in Kent and Medway can do that and is best placed to do that. And the work we've done in the last year builds us towards that. Thank you.
So I'm going to use the mic, so I'm moving around so you don't fall asleep, because this is really the fun bit. So I'm going to take us through the finance position. It was a really weird year, and I'm going to try and contextualise about the ICB finance position compared to the system position. But first of all, I've gone backwards. First of all, you've got this in your pack. This is just where we spend our money currently, that £4.2 billion, an enormous amount of money. We still spend the vast majority of it in acute services. Over half of our spend is there. But we do significantly invest in primary care, community services, and mental health. The running of the ICB, Paul touched on, that was 20% lower than the previous year, and we've got a further challenge in this financial year to take that further down. But significant investment in the population. I'm going to try not to lose you in this bit. So I wanted to contextualise. We had, if you get to the bottom, a really unusual position in Kent and Medway that as an ICB, we had a significant surplus. The way that NHS funding works is that we are given a total resource for the system in Kent and Medway. So as an ICB, we are held to account for the delivery of our financial position, but the providers as well. And as we work with NHS England to agree our plan, we have an overall control total. So in our planning process, we went to NHS England and said, we will work through, but we have significant pressures in a number of our providers. That means they will deliver a deficit, which is outside of their statutory duty. But the NHS is held to account at a national level for its plan rather than locally. So we agreed with our local providers the level of deficit that we would take forward to NHS England and agree, and they set their budgets on those, they worked with their teams on those, and it recognised the true pressure within those organisations. We then had a number of conversations with NHS England, and they agreed our plan, but also funded some of the pressures that they recognised. What we did in Kent and Medway, in agreement with all of the providers, is the ICB held on to that non-recurrent money that they gave the system. So the plans that had been set in organisations such as East Kent Hospitals were known and owned in that organisation and truly reflected the ongoing recurrent pressure they had, rather than being hidden by some of the non-recurrent funding we had that we received later. So there's a real oddness that we had a number of organisations that agreed a deficit plan, and the ICB sat there on a reserve that seemed incongruous with where we were. It's important to note, though, it didn't stop us spending the money that we were signed up to, and it was just an accounting way of managing those funds. So there's a bit of a story here. Positively, we ended up delivering better than we said with NHS England. So during the year, as with many other systems, we agreed a revised control total of a deficit of £93 million. But working collectively across the system, we were able to take some cost out and deliver an overall deficit that was smaller than that, so a £60 million deficit, and the ICB delivered its financial position. Hope I didn't lose you on that. I'm happy to bore you to death about that at the back of the room later if you want to get a bit more clarity. So, the bits that we go through, we achieved our statutory duties. We delivered the agreed financial position and had an unqualified opinion from our auditors. We submitted all our accounts online, and importantly for us, we delivered the mental health investment standard, we delivered our control total within our running cost budgets. Positive. But as with other areas, we had significant increase pressure on the efficiency and productivity. We had a significant savings target last year. We had the continued challenge, as we do each year, of balancing our resources, our demand, and the improvements that we want to make. We did reduce our running costs. It says in here we had an ambitious target to deliver 109% of activity. So in a drive to reduce our waiting list, NHS England asked us to deliver, it says 109, so 9% more activity than we did in 1920. That costs, for us as an ICB, £500 million. We actually, as a system, spent £555 million on elective activity last year. So we gained, from NHS England, a further £55 million to spend on elective patients in our population. Majority within our local providers, using the independent sector and providers outside of Kent and Medway to support trying to reduce those waiting times. Really positive news. And again, we're planning this year to deliver more than the expectation so we can treat more patients. And we continue to work as a system. It is a system control total we're held to, but we're working as a system to both move patients around to reduce waiting times, but to manage our funding more efficiently. So again, as Paul did, into the new financial year, the challenge doesn't go away. We have probably the second largest savings plan in the country as a system. It is going to be very challenging. We can't do that by doing the same again and again. So working as a system, breaking down those boundaries, delivering transformation at health and care partnership level is really important so we can deliver what we need to do, deliver the care we have within the resources we have. We are doing lots of work as a system about sharing best practice, working the best ways of working and increasing our productivity and throughput. And for us, one of the big steps on that will be for this financial year to the delivery of our NHS strategy and the longer term recovery plan. So we're working on that now to get that embedded into delivering this year, delivering 5 years and 10 years. That's me. So I'm going to pass to Natalie.
Thank you, Ivor. So it's time for some questions. If anybody's got any on the speeches that have gone, there will be another chance for questions after the final presentation too. Oh, sorry, lady at the back. Hello. Could I get a mic there? Thank you.
Is it already good? Angela Harrison, Swellborough Council, Chair of Housing and Health. So we're part of the 80% that affect residents' health. You're part of the 20% because we are part of the wider determinants. Paul, just find my notes just here, talked about life expectancy. So I have to declare a pecuniary interest because on the Isle of Sheppey, my life expectancy is 10 years less than people who live on the mainland in Swale. I know there are people on the mainland down in Thanet and parts of Medway, but 10 years. So please up your game quicker. That's why I keep coming over to meetings. You talked about working with the HCPs, and this is, I was going to ask this in the main bit, but Paul mentioned it. Now, we spoke before the ICP, the ICB was set up about no one size fits all, about horses for courses, about the HCPs knowing what is best for their area and coming up with local solutions for local problems. So my concern is that you are issuing Kent and Medway wide tenders for services on a one-size-fits-all. That is not what the agreement was. I think you really need to visit that, Paul, and your colleagues to make sure that you are doing what we said on the tin, which is making sure that we are targeting resources at the areas of greatest need, rather than trying to spread the jam so thinly that some people don't even get a sniff.
Thank you. So a question, so H&CPs for everybody at Health and Care Partnerships, you'll look at that presentation, but just to be clear, question really for Paul around how we divide the resources up, that delegation to Health and Care Partnerships and life expectancy, bearing in mind the 80 and 20%.
Yeah. Thanks, Councillor Harrison. It's helpful as a question. We do some things on a Kent and Medway footprint. You're absolutely right. And we also do some things on a H&CP footprint, and we also do things by primary care networks, which are smaller in themselves. In terms of the physical community procurement, which is going through a process at the moment, that will be done in 4 H&CP areas. That won't be just once. And for adults, it'll be done in 4 geographical footprints, and for children, it'll be done in 2. And what we hope to do by doing that is to take into account the starting point, because one of the things that the ICB has inherited is very significant variation about how services are delivered at the moment. That's a legacy issue. That is not a criticism. We used to have 8 clinical commissioning groups in Kent and Medway. They all contracted in different ways. They all contracted for different things. But what we do think is that we can learn from each other and have the best practice translated. But those contracts specifically will be issued across, individually, the HCPs. So we might end up with 4 providers, 6 providers. We might end up with a different configuration, but your point is well made, and I accept it.
Thank you, Paul. Question there, gentleman there. Thank you.
Thank you. Richard Bryce. I'm a GP in Whitstable PCN and clinical director. I'd just like to follow up on the previous question and this idea of the tenders being made across, which are quite wide patches, especially in East Kent. It's almost half of the county, half of the population of the ICB. And the idea being, as I understand it from the centre, that if contracts are awarded on an HCP basis, then even if there is one contract for one prime provider, that prime provider is given the duty to collaborate with other providers so that you get services that can be delivered locally, which sounds great in practice. But my HCP area is huge. We only have one provider that could be the possible provider for many contracts, and that's East Kent Hospitals Trust. And we know from experience that when we have offered to help them with capacity at less than tariff, so the patient wins getting a service closer at home that is more accessible with a shorter waiting list, and the taxpayer can benefit from having a service provided at less than cost of tariff. ECHA frankly don't have the bandwidth to engage because they have so many of their own problems. And so we get a total stasis with community providers that do have the capacity to innovate and provide arguably better care closer to home at less cost to the taxpayer, but it can't happen under the prime provider model.
Thank you. So I'm waiting for the question.
So can we look at contracting at a smaller scale than simply one prime provider across a huge geographical patch?
Yes.
Okay, thank you. I'll wait.
Thank you. I'm going to take one of the questions we got in advance now, which was around the publication of the Lord Darcy report, Paul, where the question was around what are your reflections on that? What do you think that means for health service strategy going forwards? And do you welcome the report as published?
Thank you. Thanks for that question. Just for those who may need a bit of introduction on that. So Lord Darcy, who is still a working consultant surgeon and is a member of the House of Lords and previously was a health minister, was asked by the incoming government to do an investigation into his views on the health service as it stands at the moment. And that investigation was published about 2 weeks ago. To answer the question, Natalie, I think it reflects the ask that was made. So I think that if you read it, and I think it's a well-written report and it's helpful, what it does is it recognises the position at the moment. My observation, in addition, is that whilst it recognises what happens, and I think there's some really helpful insights within it, so slightly to earlier questions, it identifies that 13% of hospital beds are occupied by patients who would be better looked after elsewhere, position I recognise in Kent and Medway. It recognised the impact of weights and the impact that has on individuals, and it also recognises the need for the very best workforce that can be available to the NHS, but also the need for leadership and the central role of management and leadership in the health service. So all of that I think is supported, and I recognise it, and it's welcome. What it didn't do, and what it wasn't meant to do, was to set out, so what do we do with it? And I think that is what comes next. So what comes next is a 10-year plan for the NHS that I hope will be published in the spring of next year, building on the conclusions of Lord Darcy's investigation and recognising where we are off the back of a pandemic. So to answer the question, absolutely, yes, I do recognise it. Yes, it has a resonance in Kent and Medway. What we do about it, for me, is much more important. So I look forward to looking at what happens in 10 years, but my answer is caveated. We can't wait until the spring. We have to do some things now. So as we take forward our integrated care strategy, as we take forward our NHS strategy, we need to make sure that that starts to pick up the things that was reflected in Darcy.
Thank you. We are going to move on to the next presentation now. There will be a chance for some questions at the end, but if I could welcome to the stage Rachel Parrish and Dr. Rakesh Kauria to talk to us about the out-of-hospital care work that they have been doing.
Okay, is that a bit better? Yes, I can even hear myself. Lovely. Thank you very much, everyone. So thank you very much for the opportunity today to highlight some of the work of the out-of-hospital team in this forum. We're going to spend a few minutes giving you a flavour of our principles and approach, the work we undertake, and how this is starting to have an impact on the people that use our services in Kent and Medway. When we talk about out-of-hospital care, we mean care that's provided outside an acute hospital setting, in the community, in people's own homes, and also those that reside in care homes. Ooh. I don't seem to have all of my slides. Okay, my jigsaw's disappeared. Anyway, so I was going to show you a nice picture of a jigsaw that had a number of areas of work included in out-of-hospital care. And effectively, what I'd intended to do was share with you some of the breadth of the portfolio and essentially articulate by showing you our jigsaw that bringing together a joined-up approach for transformation of out-of-hospital care in all of those areas is really pivotal because, of course, people use multiple services and pathways, and therefore they need to be able to fit together in order to provide a good experience for people. Rakesh and I have been leading... Oh, they fixed it. Back. Rakesh and I have been leading the programme together for around 18 months now, and it started with a large event in Canterbury that included partners and stakeholders from all sectors and people with lived experience to create our aims and ambitions. No, I don't have our aims and ambitions either. Bear with me. No worries. I would sing a song, but you might leave really quickly, so I won't. There we go. few. You don't want me singing, for sure. So yes, so as you can see, I've talked to the jigsaw slide. So what you can see also from here is that we're talking about bringing together at the Canterbury event stakeholders from across Kent and Medway, and therefore we're, as an ICB, we're not doing all of this work in isolation. We're working with our community provider collaborative colleagues, with our hospices for end-of-life care, you know, and people with lived experience as well. So. Yes, excellent. Right, so our aim for Ageing Well. So it's really, we want, well, our ambition is to enable those that are ageing and living in our communities to receive the best support and care that they need in the place that's best of them. And we want to move to that model of care where we'll be guided clearly by the voice of our ageing communities. But we recognise, I think we've spoken about this today in terms of the prevention approach. Ageing and dying is not just a medical matter, it's a societal matter. So we want to ensure that we engage and support everyone in Kent and Medway. The benefits of this, of course, are around enabling people to age well and stay well so they enjoy the best quality of life for the longest time. We all want that for ourselves and our families. And that personalised care is provided and based on what matters to individuals. And this supports treatment of patients in their own homes and reduces unnecessary urgent care attendances and hospital admissions. And we all know that the less time in hospital is the better for all of us. So you'll see reflected in our Ageing Well pillars that prevention, proactive and reactive care approach, and also some areas where we are paying particular attention to because we know that's required. And a couple of those we'll draw on this afternoon in terms of end-of-life care and care homes. Our Ageing Well model of care follows that same approach, and you'll see if you just look towards the bottom of the slide there that we want to ensure as people move, we're providing a preventative approach, proactive care, and then that reactive care is provided as it's needed. But we recognise that people have differing needs at different times and therefore move up and down the pathway at different times. So that takes me on to, it's really important that we focus on prevention and proactive care. Knowing what we need to, or knowing what we know about the increase in our population in the coming years and the increase that we have predicted in our rate of long-term conditions, we've focused on approaches which we believe will set us in stead for the future. We're at the beginning of our journey, and Rakesh is going to describe to you a little bit about some of the areas we're particularly paying attention to, which is around neighbourhood teams for complex care, care homes and end-of-life care. And I will hand you over to Rakesh.
Thank you very much, Rachel. Thank you. Okay, great, thank you. It's a real privilege to be given this opportunity as a clinician to take part in our annual general meeting, so I'm very grateful to our seniors. If I asked you what is the most challenging thing we face today, if we asked our citizens what is challenging for them, they will probably say three things. Accessing the service when they want to. They will talk about having to repeat their stories and the care coordination. And then they will talk about when they have to navigate the services, it's really difficult to know how to do it. We've already heard from our seniors, from Rachel, that we have communities which are living longer, which is excellent. But we also within that have a challenge that these communities are not necessarily, me included, going to live in a healthier life. So we're going to live longer with more long-term conditions. And if we're going to address this, we need to develop this, what we call integrated neighbourhood teams. So we can have better same-day access, but for those individuals who have complex care needs, are given continuity of care via multidisciplinary teams who know them, who have access to their records, and can deliver most of the care where they prefer. So in my 35 years of a GP, my last 7 years have been devoted to working in the community as an acute response team GP with an amazing team of professionals. And the GP bit, the doctor bit, is a very small bit. It's the wider team, right? So we are hoping to develop these teams so then people who have multiple medical conditions can be looked after in a really compassionate manner 24/7 as we build these teams. Now we know that inevitably some of our residents, we try very hard to support them and maximize their stay at home, but they may need to go into a care home. We know that with the aging population, dementia is also a big challenge for us. We have one of the largest numbers of care homes in the country. In a way, we're very pleased that people want to come and live in Kent and Medway. But we also know historically these particular group of individuals. So in DGS, we have 45 care homes. In Medway and Swale, 106. In West Kent, 108. In East Kent, wait for it, 308, right? We have, as we heard from our seniors, historically invested to look after these citizens. But the care, with the best intention, has got multiple offers and it's fragmented. So what we want to do, based on what Rachel said, is to have these prevention aims, proactive aims and reactive aims delivered by a more enhanced offer for care home residents. Where possible, we want to do even better. We want to support citizens in their homes so that they can live longer where they are, within their neighborhood, within their families and people they know. However, if they do go into a care home, we want to give them the best care possible. So all these different offers, we're trying to see how can we unify them. And we're talking to all involved colleagues, health and care, to make that happen. In particular, we know, and we learned particularly during the pandemic, that when certain times of the year come, that these care home residents could do better if they had a more enhanced offer. And thanks to all colleagues involved and our seniors supporting us, we had a special, what we call winter schemes for a number of these challenging areas. And when we look at our last year's winter scheme, which we're really pleased that will run again this year, but this time with the aims of it continuing longer term. Why? Because we are going to bring all the other offers that are in existence into this better proactive offer. So this will be a team that proactively contacts every care home 7 days a week, identifies what the issues are, make sure those issues are delivered not just by them, but by the existing and additional services. And most importantly, remember what I said, that we need care records people have access to, whether you're an ambulance person, you're a district nurse, or whether you're a healthcare assistant. So our Kent and Medway care records are really maturing and we're beginning to use them widely. We want all our care home residents to have a life plan, what we call a respect plan. So if a paramedic colleague turns up at 3 o'clock in the morning, he or she within minutes can say what is the background to this individual, what it is that the patient wishes to happen and how can they best support them. So you can see the impact that this particular model had. 2,186 care home residents had coordinated care, nearly 770 proactive care plans. And the sum total of that was that we had just less than 200 less hospital admissions, right? Imagine how less distressing is that for that individual who may have dementia, who may be frail, being in a busy ED department. This slide is really to support what my seniors were saying. These are the principles we're using, right? So the 6 national ambitions for palliative and end-of-life care apply to many things we do. For example, each person should be treated as an individual, right? Absolutely, right? Maximizing comfort and well-being. The most important thing is we want our communities to prepare to be helped as well. There is no way we can help our communities without your compassionate support that will help us to do that. All the other foundations, education, training, 24/7 access, care records, we've touched upon them. But the most important thing our seniors said, and I have seen in practice as a frontliner, that co-design is not just a jargon. The co-design to do the best for the citizen is happening, right? Leadership, I'm so privileged to have the leadership of being able to connect that, what I call my frontline worm's eye view, to the bird's eye strategic view to make things change fast. Quality of care, access and sustainability has to be standard across our 4 HCPs because we are one NHS, one ICS. We want to listen to our patients, what is working well, what isn't. We want to listen to our professionals, what will help them to improve our processes in our daily practice. I think we've touched a lot about this, but as a palliative and end-of-life care champion lead for our system, there is only one certainty in life, sadly, and that is one day we're all going to pass. What we want to make sure in Kent and Medway, that is as less frightening, as most dignified, and as most comfortable for any individual, regardless of your roles, settings, background. And we've done some amazing work with our hospices, our community district nurses, and what is really, really important is to build on another winter scheme where we had over 2,000 patients receive out-of-hours end-of-life care support coordinated by our hospices and supportive services, right? We also know that patients, when they're needing transportation, that was a challenge. And we had 350 patients outside CCAM, conveyed to the hospice in a timely manner or to the hospital from the hospice when required. I think going forwards, it is not just about those people who need help, but it's also those people who are currently well, from age 0 to age as long as they can live, having that prevention, proactive support, and then when they need it, the reactive support, so they receive the best chance in remaining well, as it says here, lead longer, healthier, and happier lives in Kent and Medway. And it's a real privilege to be a clinician and to be a member of teams that I work in. So thank you.
Thank you both. Don't run away too quickly. We may have some questions. Are there any questions on that presentation particularly? Hello, yes. And this gentleman at the front as well.
Thank you. Sorry, I'll try and make it quicker this time. Rakesh, thank you very much. I'm a big fan of the Respect tool, and I'm glad to hear there's some data showing that it's leading to less inappropriate admissions, can we say, to hospital. Are we collecting data to show that we are any better as a system in helping people to die where they wanted to, rather than in a place where they didn't expect to?
So thank you, Richard. So two things, right? We did a piece of work literally with Mairead's help in the last 2-3 weeks, right? And with Mairead's help, we looked at some data. And in East Kent, for example, and I'm not biased at all, I happen to work in East Kent, you work in East Kent. In East Kent, we have some of the most frailest population, right? So we have around 40,000 frail communities in East Kent compared to 25 average in West Kent, 22 average in Medway and Swale, and 12 in DGS, right? If you look at that and look at the rest of the southeast of England, all 6 counties, the number of people over 80 years of age who are dying in hospitals in East Kent is 16% down compared to the rest of the county and the southeast of the region, which is around 6%, right? More of our patients are dying in their care homes than they are dying in hospital. However, you're absolutely right. We do need to do more. We need to do the same in their homes. And I think the other question you are asking but have not verbalized it, fine, Rakesh, have your respect plan, but when they need that help at 3 o'clock on a Sunday afternoon or 3 in the morning, can we respond to that? And I'm so grateful to hear from our seniors that community focus, having more capacity and capability is the plan, because we know we can make a difference.
Thank you. This gentleman, oh, yeah.
Am I next? Fantastic, absolutely fantastic. I should have said earlier, there is some brilliant work going on right across Kent Medway. Now, I have had a number of older people, obviously, being a counsellor, who know they've got dementia. Well, asked about, no, they just put them in the box. And I'm very pleased that you are looking at comorbidities, because it is about, yes, people do have dementia, but don't stop them getting other things as well. And I think that your message really needs to be spread far and wide, because the quality of people's life, because they are put in that box, whether it's dementia or anything else, it is really, really sad. And people are not used to questioning. Doctors, clinicians, consultants, you name it, it's, oh no, the doctor said it was the dementia, that's why they can't eat, speak, this, that and the other. And it's so wrong. And I take my hat off to you for the work that you're doing for the older people in our communities. Thank you very much.
Thank you.
Hiya, my name is David Reith. I'm the Director of Strategy for the South East Coast Ambulance Service, the intensive support one. And it's felt, and it's needed. And you've talked about collaboration, Paul, and collaboration works. Rakesh, we were speaking earlier. There's some really fantastic work that we have been doing in collaboration with, we started in the east side of Kent, and now we're spreading some of the good practice. So just for context, CCAM operates across Kent, Surrey and Sussex, across the southeast, and Kent is the only system where year on year we've been able to see a reduction in conveyance to EDs as a result of some of the models. So that is really good. So I just want to say thank you, first of all, on behalf of CCAM, and just referring to some of the good work that we've heard from Rakesh. The second part of the question really is just if we expand on that, if we expand the collaboration, maybe it's a question for Paul, but Rakesh, interested in your views as well, and Rachel. Transformation is hard in the financial context that we're in. We've heard some of the numbers and some of the deficit that we still have. So I'm just interested in your perspective. You've proven a number of areas where transforming whilst improving and delivering care is possible. But I'm just interested to hear, next 2-3 years, what are the barriers? What do you need from your partners that are around the room to be able to continue to deliver this transformation?
Rick, can I start the question and then give a perspective? Would that be okay? I think you're seeing it, because I think what we will do, my chair bans the word transformation because nothing is transformative enough. So we need to do change. When we get clinicians on board, when we have discussions, when we have them in an inclusive and a respectful way, and when we remember that it's the 2 million people that we serve, that's how we do it. That's how we get it done. So that's at a massively macro level. The best thing that I can do, the best thing that SETI can do, the best thing that our executive can do is create the environment and then get the hell out of the way. And that's what we ought to do more of. Got to be confident enough to do it. But I think in terms of what you're describing for the next 2 or 3 years, clinician-led, management-enabled and facilitated by the wider system. It's a very personal perspective, but hear from colleagues.
No, I think you've nailed it there. I think all the work that we're doing, transformative or not, is done together as a system. So, you know, our governance forums, the way we meet and how we meet with people and health and care partnerships and provider collaboratives, you know, the governance is such that we all have those conversations about what we think, what is best practice, what's the evidence for that, what are we doing now, how do we change and grow to meet the needs of our population, and we'll continue to do that. Yes, of course, there'll always be challenges and struggles, but I think we just kind of, we're edging forward. We've outlined some principles in the way that we want to work, and you know, I think we're all really grateful that our colleagues, our senior colleagues at the ICB are on board with that. So now we just need to continue to move forward.
I think the last thing I'd like to add is that we're very lucky that, you know, for example, our CMO, Dr. Kate Langford, when she got these clinicians grouped together, there were two things she said to us. What matters to the patient, and how do we recreate the best practice that exists? Because, you know, you look at across Kent and Medway, you look across the counties beyond Kent and Medway, there are people who are doing great things who face similar challenges, right? And in our regular CMO meetings, we can share these stories, we can challenge each other. But what is so great is that through those channels, we have the connectivity with all the clinical and non-clinical leadership who are supporting us. And I think when we all focus on what matters to the patient, as the pandemic showed, right, the challenge was far worse, but because we were focusing on what matters to the patient and our seniors backed us, we can make that change. And I think we can do more.
Thank you. Are there... Dan.
Thank you. This is very personal to me, but what is your plan to support our CCAM colleagues with their scope of practice in order to change those pathways of saying, no, you can stay at home, that is your wish? So my mother was twice conveyed to Medway against her wishes because the paramedic scope of practice and their pathway was to convey them to hospital.
Yeah, go for it.
Thank you so much for sharing that story, and I'm very, very sorry that you had a relative have that experience. We want to improve that. I want to appreciate what a difficult job our paramedics do in terms of the geography they cover, but also the number of emergencies and types of scenarios they cover. But I also know that they too will join me in saying that they want to improve on what your experience was, your brother's experience was. So, here are some examples of live things that we are doing to help that. On Monday, I was at CCAM in Ashford doing what we call a single point of access. So there was me sitting with all the GP records, there was an emergency doctor consultant sitting next to me with a number of paramedic practitioners, and we were looking at the conveyances that were taking place. And a paramedic on a scene, say for example at your home, family home, with that scenario, if that was the story, they would be able to ring us so we can look immediately what the background issues are, to then find a way of supporting those needs outside hospital. That is where we've developed what we call the urgent community response teams. So it is completely normal for me when I do my on-call that I'll be talking to CCAM colleagues 10, 15, as many times as necessary when we have scenarios like that. And you know, it is very interesting. More people want to be looked after outside hospital, and that is not a negative reflection on our hospital. They just prefer that way of being looked after. So that's one example. The Kent and Medway care records is another way of making sure that that care wish is noted, the adequate medical information is there, so we can all follow those instructions if it happens to be 3 o'clock in the morning. We now have what we call PCN locality hub meetings. So if there is somebody complex who needs to be followed up, the paramedic or the urgent community response team will be able to refer them. The same applies where appropriate. I'm not saying it was in your case, but we have our hospices that provide 24/7 cover. You don't need to be known to the hospice in the old-fashioned way, that hospice only means one thing. Hospices today are about improving and palliating. Palliating is basically reducing the suffering and severity of whatever condition you have. So I hope you can see there are other options, but I'd really like to talk to you in private, if I may, to understand a bit more and how we learn from it.
Thank you, Rakesh. Any other questions? Gentleman behind you.
Thank you for your wonderful presentation. I'm Councillor Anand. My question relates to most of the elderly people in my ward wants to use the earthly living centers, but they feel that it's being underutilized. And I believe with the work that you are doing, if those living centers should give them the opportunity to go there when they need services, I think that will also be helping them to a lot. But now most of them feel if they want to go there to access services, there are no services there for them to access. So what are your plans to make sure that these centers can provide services to the elderly people within the community or their locality?
Thank you. I think that's an excellent question. Very keen to hear your views, but I'm also going to bring in Mike Gilbert, who runs the strategic estates function as well as some others to provide that, because that's been a hot topic that we've been talking about recently. Is there anything you wanted to add on it?
No, you go for it,
Mike.
and we'll pick up it.
Thanks very much. So yes, I'm Mike Gilbert, head of strategic estate, and actually, so you're talking about the Medway area particularly, healthy living centres, but actually it's not only the healthy living centres in Medway, there's also other services, NHS property services and other services across the rest of the county. I was speaking to a couple of other people earlier around about the additional charges and the costs which appear to be driving out some of the services within those areas. This is a national issue, but I'm determined locally to work with colleagues within the NHS, within the local authorities, to actually come up with a dynamic way that actually will encourage GP partners, community health services, social care colleagues, local authority colleagues, the voluntary sector as well, to improve the utilisation of those healthy living centres. They're amongst the best quality buildings we've got in the county at the moment, and yet the utilisation rates or the void rates, so where they're empty, are between 10 and 20% of empty rates within them. Rainham Healthy Living Centre is a particular one as well. So we're working an awful lot to increase that utilisation, and in fact I've got a meeting tomorrow to absolutely talk about this in terms of with property services and with community health partnerships about what are we doing and what can we do with them in a dynamic way that reduces service charges, that reduces the increase in cost and therefore increases the utilisation rates.
Thanks, Mike. Are there any other questions from the floor? Yes, gentleman behind you. Abby, thank you.
Thank you. Good evening. I've got one which is not really about the presentation, which is great. Thank you very much. It's really a general one, the problem I come across today. A pharmacist you mentioned earlier, which is a pivotal part of actually providing primary care to patients. What I saw today was a notice in a pharmacist from a group of GPs that run half a dozen surgeries across Medway and one into Swale, which states that patients from the end of November cannot ask their pharmacist for a repeat prescription. They have to either go on the NHS app, and that's where this poster is pointing, or they have to actually drop a paper request into their surgery. Now that, when we talk about the 80-20% rule, 80% of people are quite happy with technology, but there are 20% which aren't. And this is really, how are those 20% of people going to actually get their repeat prescriptions? Majority of those will probably be elderly people. So my question is this actually an ICB strategy, or is this group of practices gone off alone? I've heard other whispers today that that's happening in other areas. Thank you.
Thank you. I may bring in Dr. Kate Langford, our medical director there, and Suk, if there's anything you wanted to add as well to that. Thank you.
Thank you. So that particular instance, that's not something that's driven by the ICB. Very happy to pick up that particular detail. The app is a thing that we're very keen to support, because for many people it works really well. You can book your vaccinations through it. If you're able to, you can manage your repeat prescriptions through it. So definitely support for the app is, but it's absolutely also something we're very mindful of to make sure we don't exclude people who are not happy in that digital world. So no, insisting that people do use a digital front door is definitely not part of our strategy. Our strategy is to be inclusive and make sure that everybody has the right route in. But be very happy to pick up the details of that some other time.
Thank you, Kate.
Do we just want to let Dr. Bannott say something, because he's one of our digital people?
Just to add, so in my practice, we've got one of the highest NHS app usages in Kent and Medway. We started very early, and as new functionality, as Kate's mentioned, came in over the years, the adoption rate has increased and increased, and we've always been quick to encourage patients to do those things. We've got one of the most elderly populations in Kent and Medway in my practice area, and we've got one of the highest utilisation rates. So I thought and imagined age would be a barrier, but actually it's not been. We also worked really hard to make sure we had community Saturday clinics, and my staff going to community centres, people bringing their iPads and their phones and helping them install apps, as well as the ability to do that at reception if they just turn up. And that's been really powerful as well, and help support our communities to take up these new tools. And the other great thing has been that all our staff really have a good understanding of setting up proxy access, so that people's family members can do it for them if needed, or they can get access for their children, for example. To stop that exclusion, we still accept patients ordering prescriptions via either a telephone call or a bit of paper, like the old-fashioned. But actually, that's become a very small minority, and we have set up also a specialised bypass number, a telephone number for those patients that need it. So if they need to order their prescriptions every day for 2 hours, there's a telephone line that's easy to get through, because not many people use it to order their prescriptions over the telephone. So, as Kate said, we don't want to exclude those that digitally, because of digital tools. But at the same time, if we've got the majority can use those digital tools, and they can use it for all sorts of other things as well as ordering prescriptions, that means that then we have more time to deal with those that can't. And actually, it means our phone lines are freed up, which is a massive thing. If you imagine, we used to get 100 phone calls a day for patients phoning up saying, "Are my blood results normal?" That's disappeared, actually, because people now check the results using the app. And it really has freed up our lines, so we can now make them available for those that really need it for emergencies, or for those that want to make a phone call and order their medication.
Wonderful, thank you very much. Any further questions from the floor? No, we had one other question submitted in advance, and we just got a few minutes, and I think it's absolutely relevant to the work you're doing. It was around our readiness for winter. How confident are we? Are the plans in place? What's the sense of this winter coming? And it may be something you want to consider, and perhaps Paul as well, to give that overview.
So I'm not totally in control of the winter, although I don't suppose any of us are. But I am aware that there is a winter plan that we've all been contributing to, and we've had one winter event as a whole system, and there's another one coming up. And there are, as we referred to earlier, certainly in the out-of-hospital area, a number of schemes, including that around care homes and end of life, where there are an additional focus and schemes included to provide additional support over the winter. But I don't know whether there's anything further you wanted to add to that.
It's very marginal, Rachel. So we plan, ironically, our planning for winter starts in June. So we've been planning, and what we look at is what we need to do in terms of numbers of additional hospital beds, extra capacity outside of hospital. All of that is a work in progress. We're not quite there yet. We're working through our health and care partnerships, colleagues in the trust. But what we anticipate and plan to do is that will come back to our board for approval in November, the next time we meet. So we're getting there, but we haven't finished all the work yet. But it's always a continuous process.
Thank you. Oh, another very helpful additional guest speaker.
I just wanted to, actually, my GP hat's on here. I'm a GP in DGS in the north, in Dartford, Greater Swanley. Last year we had a bit less funding for acute respiratory hubs, as they were called the year before, but it was more of a general overflow hub last year. They were really successful in DGS in that we were able to mobilise very quickly as a GP federation and increase that capacity over winter. The year before there was a bit more funding. Last year it was a bit less. I guess my comment is that they work really well. As a GP, when I'm kind of triaging on the day and trying to get people into slots, we always go over capacity. Certainly when we had the Group A strep problem, it went up, God knows how many times, about 200, on one day we had, I remember. So I think if we can really, as you said, in place, push some of that funding down to GPs for us to make decisions with it and to primary care, and give us that resource, those extra appointments. We've got teams, we've got locums, we've got people that can do these things and provide these appointments. But it'd be great if we could have a bit more capacity, because there is just so much of it. Certainly, Pharmacy First will be a big help this year, I'm sure, actually. So I don't underestimate the value of that. But certainly, that acute respiratory input would be amazing if we could get it again.
Thank you for that. And I think that was absolutely echoed, those that had a chance to look at the market stalls around the work the Health and Care Partnerships are also doing in terms of readiness for winter too. So any final questions? No. Thank you all so much for coming. Oh, sorry, one at the back.
What are Kent and Medway NHS doing about the, on average, over 40,000 missed appointments every month? Now, when you moan to me, I can't see a GP, Ange, I say, ask your neighbour if they're one of the 40,000. But it is a serious issue, and it is such a waste of our precious resources. So is there anything that you are looking at doing? Thank you.
So those are patients who have booked an appointment and failed to turn up. Yes, there's a significant amount that we were doing, and I'm looking around the room to who would like to take this question. Suk, I'm afraid it might be you.
So there's a number of things I think we try to tackle it. So we've had, for example, two-way messaging, so trying to make it as easy as possible for people to be able to cancel their appointments. So you can do a text reminder and say, here's your appointment that's going to be tomorrow, but you can also cancel that via your text message, so not having to phone and wait on the phone line. So we just want to make it as easy as possible for people to cancel their appointments. The other thing I think we do have to recognise is that quite often there can be multifactorial reasons why people do not attend an appointment, because it may be particular challenges they've got in their lifestyles, there could be other issues that they're experiencing. So I think there's also a bit around just trying to understand that population, and particularly where it might be a thing that continues to happen, is that maybe there's a bit of broader support that's needed, maybe more social supports, other things that are kind of affecting their lifestyle that we can help with. So I think there's a couple of things that we can look at. So obviously we try and put the messages out, but just try and make it really important to say, actually, if you release this appointment, someone else can then take that capacity. But there are kind of things that we've looked at in terms of technology that just support the immediate kind of areas that we're looking at. But I do think there's a bit around actually just trying to look at the patients that maybe did that quite frequently, and then maybe it's a bit of a broader support that we can offer.
Thank you, Suk. So we're just about out of time now as well. If there have been any questions that have been sent in through the link that some people have had, particularly for those maybe viewing virtually, we will make sure that every answer to every question is up on our website shortly. Thank you very much to all our speakers, particularly Rachel and Rakesh, but Paul, Sedi and Ivor too. Personal thanks from me to the communication engagement team for putting on the event so well. And I hope to see you all soon, and certainly for next year as well. Thank you all for coming.